Hello and welcome to Synapse. Happy New Year to all the Synapse followers. This is Dr. Sonika, and in today's video lecture, we are going to be talking about acid-base imbalance. So, the topic of acid-base imbalance is, extremely important from the entrance point of view. And apart from that, even when you go to your clinics and when you see patients, whether you are a physician or you are a surgeon. Acid base balance is a very fundamental concept that needs to be understood so as to manage the patient efficiently. So what I mean is, even though we say, okay, we surgeons, we don't have to learn this concept in detail, but it becomes very essential because, see, post operatively the patients might go bad. Okay, for example, the patient might be in sepsis, or the patient might go into morphine intoxication. So even though the surgery went on well, but due to the general condition of the patient, okay, the outcomes may not be very good. So you need to be in a position wherein you can analyze and interpret the ABG results of your patient and take effective steps in the management. So that is the reason behind making this video. Okay, so let us start here. So we're talking about acid base imbalance. Okay, so here we're purely talking only about the concept. Okay, so there are 5 steps that are involved in reading and interpreting the ABG results. Okay, so the first step, okay, is to know the patient's condition. Okay, so what do you mean by patient's condition? What is the history of the patient? Okay, so whether the patient is a known asthmatic, or is he a known smoker so that he has COPD? Does he have any respiratory condition? Or is he a surgical patient? Is it post-operative? Okay, or is it because the patient is in sepsis? Okay, is he a diabetic patient? Does he have diabetic ketoacidosis? So these are all the general data regarding the patient that you need to have, okay, before you interpret the results. So the second step is to look at the partial pressure of oxygen, that is PaO2, correct? So partial pressure of oxygen, so you need to know certain normal values here. You keep looking at these values again and again, write it down on a piece of paper, put it onto a wall, see it every day. So these values will become very natural for you to remember. Okay, so PaO2 is normal is between 10 to 14 kilopascals. This is the UK system. If you are preparing for PLAB or you're doing your MRCS, MRCP, so the values would be in terms of kilopascals. But for the USMLE and our Indian results, we get the results in terms of millimeters of mercury. Okay, so normal is between 75 to 100. Okay, that's about PaO2. Next, the next value that you need to see is the pH. So we know that anything between 7.35 to 7.45 is the normal pH. Anything to the left is called as acidosis. Anything towards the right or more than 7.45 is called alkalosis. Okay, that's simple. Next, we need to look at the partial pressure of CO2, PaCO2. Again, we're going to be telling the values in terms of 2 units, that is 4.5 to 6 kilopascals is normal, and if it have to be in terms of millimeter mercury, you can remember it like this. So how do you remember this value? Just remember this 0.35 to 45, just convert it, becomes 35 to 45 millimeters of mercury. And the last step is to look at the bicarb level, HCO3 level. So this normal value is between 22 to 26. Basically, we take the mean value of 24, but remember, anything between 22 to 26 millimoles or milliequivalents per liter is considered normal. And also, sometimes you get what is called the base deficit, base excess. Okay, so what is base excess? It means when bicarb level increases, it is calculated and represented in terms of base excess. So you get it as somewhere between the ranges +2 to -2. So this is considered as normal. Okay, so let me go over this again. So there are 5 fundamental steps. Okay, you follow these 5 steps in the particular order that has been told here. You will never go wrong in interpreting the ABG results. Okay, so first is to look at the patient's condition. Okay, it could be your question stem in your PG entrance exam, or it could be your patient in the ICU. Okay, so you need to know the condition of the patient first, and then you're going to look at the partial pressure of oxygen, know the normal levels. Then you need to look at the pH, and then the PaCO2, finally the bicarb level. So we'll take up some examples to see this as well. So how are we, what is the sample that we're going to use? It is called as ABG. So I'm referring to ABG since a long time. So what is ABG? That is, it's called arterial blood gas. Okay, ABG stands for arterial blood gas. So we are going to take the arterial blood. So the sample is from the artery. So normally we choose the radial artery, if not the femoral artery. Okay, and we are going to put it in a syringe which is containing heparin, and then we are going to transport it to the laboratory as soon as possible in a cold container. Okay, and the results are to be interpreted as early as possible, because the oxygen and the CO2 that we're checking is the soluble part of the gases. So if you leave it outside for a longer duration, so it will escape from the blood, so you will get faulty results and the interpretation might be wrong. Okay, so these are the 5 steps. Just remember the 5 steps that we have learned as of now. When you look at the acid-base imbalance, so when there is an imbalance in the body, what does it try to do? There will be a compensatory mechanism. Whenever there is any imbalance, there will be a compensatory mechanism that the body will try to bring in. Now this is all about physiology. This is all your homeostasis is all about. Okay, so there are 4 combinations. Okay, so you could have, I think this is basics everybody knows. Respiratory, you could have acidosis, respiratory alkalosis, or you can have a metabolic acidosis, or you can have a metabolic alkalosis. So these are the 4 possible imbalances in the body. Okay, these are the 4 acid-base imbalances that can occur in the body. Now the compensation to this is, just see, it's very simple. When you are saying respiratory acidosis, the compensation is going to be metabolic alkalosis. As simple as that. Just change the respiratory to metabolic, and if acidosis, change it to alkalosis. Now you guys will tell me respiratory alkalosis will become metabolic acidosis. The opposite of metabolic acidosis will be respiratory alkalosis, and metabolic alkalosis is respiratory acidosis. As simple as that. So this is the compensatory mechanism. Now what happens if you have seen your MCQs? Okay, what they are going to try to do here is, it's not they're not just asking what is the compensatory mechanism. They're going to ask you whether it is compensated, or is it uncompensated, or is it partially compensated. Now let me tell you, when I appear for my exams, I was confused about this point too. But there is a very simple technique that you can use to understand this or arrive at the answer. So first I'll just write down uncompensated, partially compensated, and something that is called fully compensated. Okay. So if it is uncompensated, let's say there is a primary defect. Okay, there is a primary problem. Okay, let us say it is a respiratory acidosis. This is the primary problem. Okay, so what according to us is the compensatory mechanism? It should be metabolic alkalosis, right? Okay, so metabolic alkalosis meaning bicarb will be high. See, anything when you say respiratory is pertaining to CO2. When you say anything metabolic, it will be pertaining to bicarbonate. As simple as that. Okay, respiratory is with carbon dioxide. The metabolic is with the kidneys. So hence the bicarb levels. Okay, so in the uncompensated state, what happens is, in respiratory acidosis, I just said it is the CO2 levels. Okay, acidosis means CO2 will be increased, means H plus is more. Okay, so here normal we have told CO2 is 35 to 45, correct? So in this case our PaCO2 might be 50. Okay, let's say in this patient the PaCO2 is 50. Now what should the body do to compensate? The bicarb level should increase, okay, because the H plus is increased, so you should try to increase the bicarb also, so that the pH will come back to normalcy. Fine. So now what should happen is bicarb should increase, but let us say in this patient bicarb level is 24. That means there is a primary defect, but the other wing, the other end, okay, of the system is perfectly normal. It is not yet responded. It is an acute state. It is an uncompensated state. Okay, I think I have made this point clear. So let us go to the partially compensated state. Now what does partially compensated state means? Again, same example, respiratory acidosis. So you should have a compensation of metabolic alkalosis, correct? So acidosis, let us say our acid PaCO2 is again 50. Now body is trying to compensate for this abnormality. So what it's trying to do, it's trying to increase the bicarbonate. What is the bicarbonate here? Let us say it is 33. Normal is between 22 to 26. Now bicarb level has increased to 33, and you see both the levels are not within normal range. Okay, so this is a partially compensated, as in the body is trying, okay, but it's not there yet, it is trying. And one very important thing here, the pH will be, now in the primary defect is respiratory acidosis, so let us say the pH here will be 7.2, meaning it is acidotic. Now when I say fully compensated, very simple to identify, your pH will be between 7.35 to 7.45, because your body has completely compensated the imbalance and you have arrived at an equilibrium state, at the balanced state, where your pH is lying between 7.35 to 7.45. That becomes very easy method of understanding and categorizing the situation that is given to you in the exam. Okay, so now with this thing understood, let us move on. And there's one more concept that needs to be understood, that is the concept of anion gap. So what do you mean by anion gap? Okay, so the definition of anion gap is you put all the cations together and minus the anions. Okay, now why is it called anion gap? Because see, normally what happens in our body is we have a number of anions which cannot be counted, which cannot be measured, because they will be bound to proteins. Okay, so they will be bound to proteins, but your cations can be easily measured. So that's why we take cations minus anions, and hence though it's not called cation gap, it's called anion gap. Okay, fine. So this is the formula. Now what really happens is, in our let's say acid base imbalance, the bicarb is the one which is getting affected. It may increase or it may be decreased depending upon the whatever type of imbalance there is. Okay, now once the HCO3 value reduces, okay, what happens to anion gap? When this factor reduces, the anion gap increases. So when the bicarbonate level reduces, the anion gap, here I'll refer to as AG, increases. Okay, as simple as that. Now next is, what happens to when your bicarbonate level increases? When the bicarb level increases, the anion gap decreases. As simple as that. Now why is this concept important? Because when we have the concept of metabolic acidosis, okay, we have two things. Okay, see, what is metabolic acidosis meaning? Either your bicarb is less, okay, this is what is the definition of metabolic acidosis, right? Your bicarbonate will be less, okay, or your H plus could be kind of more. Okay, your kidneys are not throwing out H plus, so there could be buildup of H plus, or there could be increased loss of bicarbonate. Either of them will result in metabolic acidosis. Fine. So there are two types of metabolic acidosis. You can have a high anion gap metabolic acidosis, or you can have a normal anion gap metabolic acidosis. So this, it's called as hagma or nagma. Okay, so this is a very important concept. Okay, so I hope I have made myself clear. Okay, so when there is metabolic acidosis, there are two possibilities of having it. Either your bicarb level is less, okay, so that your, you know, bicarb, the whatever causes the alkalinity is gone, so you'll have acidosis, or your H plus could be more because of lack of, losing the H plus in the urine or by the kidneys basically. Okay, not involving the respiratory system. So that's why I have not taken the lungs here. Okay, so these are the two possibilities of having metabolic acidosis. Now in that, if the bicarb levels will decrease, so what will happen? It will become a high anion gap. Very simple, high anion gap, which we have just seen in the previous formula, correct? Now if your H plus increases, because H plus is not taken into account in your anion gap formula, if you just saw that, sodium plus potassium minus KCl, sorry, plus HCO3 minus. So there is no H plus, which is being depicted in the formula. So your anion gap will remain the same. So this is called normal anion gap metabolic acidosis. Okay, so now what is important in this hagma and nagma is, there are a set of conditions that you need to remember. There are very popular mnemonics for this. Okay, they'll ask what are the causes of hagma, what are the causes of nagma. So the mnemonic for hagma is mud piles. Okay, everybody knows this. It's called mud piles, and the mnemonic for nagma is called hard up. Okay, so I'll just write down the mnemonic, mud piles. Okay, so what does this stand for? So M is methanol, basically alcohol intoxication. Okay, then U is for uremia, D for diabetic ketoacidosis, P stands for drugs like propylene glycol, okay, or fenformin consumption. Okay, I is for drugs like isoniazid, L for lactic acidosis, E for ethylene glycol, and S is for salicylates. Okay, that. And then next mnemonic for nagma was hard up. So H is for hyperalimentation, A is acetazolamide, R is for RTA, that is renal tubular acidosis, D for diarrhea, and then U for urethral diversion. So what happens is, there are certain procedures following CA bladder, where we are going to create a new bladder or take the urethra and then anastomose it to a part of the ileum, so where the urine is directly drained into the GIT. So in those procedures also there can be metabolic acidosis. The last P is for pancreatic fistula. So these are the causes for normal anion gap metabolic acidosis. Okay, so this is purely from the entrance point of view. So now we have learned what is acid-base imbalance, what is meant by compensation, what are the phases of compensation, and what is anion gap, what is hagma, nagma, and what are the reasons for or causes for this condition. Okay, so lastly I want to mention about something called as respiratory failure to complete the topic. So what do you mean by respiratory failure? It means that the PaO2 level becomes less than 8 kilopascals. So we have learned that the normal PaO2 varies from 10 to 14. So anything less than 8 is called as respiratory failure. So there are two types of respiratory failure. Once this criteria is met, that is termed as respiratory failure. After that, we have two types. So we have type 1 and type 2. So this is based on the PaCO2 levels. Okay, if PaCO2 is either low or normal, it is type 1 respiratory failure. If the PaCO2 is increased, okay, then it is termed as type 2 respiratory failure. Okay, so I hope I've tried to make things simpler. So that's all you need to know, and with this knowledge you have to just go in and do your Q banks, practice some questions, so that the concept just gets cleared up in your mind. So now let me just try to give you an example so you can test yourself, okay, with this question whether you have really understood the concept or not. So there is a person who has a patient who has undergone surgery in a post anesthesia care unit, okay, and it is right now the patient is in the basically the ICU care, and it is difficult to arouse this patient, okay, following surgery. And there is a nurse who has been giving the patient morphine sulfate IV, okay, because the patient is complaining of post-op surgical pain. So the client's respiratory rate is, now the patient's respiratory rate is 7 per minute, okay, and the patient is having shallow breathing, okay, and the patient is not responding to any stimuli. So the nurse is now going to call you up and she's going to update you regarding the stats of the patient, and she's sent you the ABG. So she is telling you that the pH of the patient is 7.10, the PaCO2 is 70 mmHg, the bicarb levels are 24 milliequivalents per liter. And what is this patient's status? Okay, so that is the scenario given to you. Okay, so fine. Now with this question, okay, let us apply our 5 steps of ABG analysis here. Okay, so the first step we told is to look at the patient's condition, correct? So what was the history told? It is a post-op patient. Okay, so patient had surgical site pain, so the nurse has given him morphine. Okay, she has given him morphine sulfate. Fine. After that, the patient has become drowsy. Okay, the respiratory rate has fallen down to 7. Okay, patient is having shallow breathing. Fine. So that is the condition of the patient. Now it's very simple. What morphine does? Morphine reduces or decreases or depresses the respiratory system. So this is a respiratory issue. This is a respiratory issue. Okay. I hope this is clear from our step 1. Now let us move on to step 2. So step 2 was to look at the PaO2, correct? So what is the patient's PaO2? That they haven't mentioned. That's okay. Fine. Now next is to look at the pH. Okay, what is the pH? pH is told as 7.10. Now you know that this is to the left side of the scale, so that means it is acidosis. It is acidosis. Fine. Now what is the next step is to look at the PaCO2. What is PaCO2? 70. Normal was between 35 to 45. Now PaCO2 has increased. Very simple. Does it go with our first statement? Is it going hand in hand with the first point that it is a respiratory problem? Yes, of course it's a respiratory problem. So it is a respiratory acidosis. Now what is the last step? To look at the bicarbonate levels. What is it? It is 24. Is 24 normal? Yes, this is normal. So now what is the primary problem? Okay, I'll write it with a different color. Now what is the primary problem? It is, okay, hold on. Yeah. So the primary problem is respiratory acidosis. Fine. Now look at the compensatory mechanism. What is it supposed to be? It's supposed to be metabolic alkalosis, meaning your bicarb should be increased. But is it increased? No, it's not. So it is an uncompensated respiratory acidosis. Okay, so I hope you guys understood how we arrived at the answer. Okay, fine. So if you're thinking that you got a hang of this, here I have another question for you. Okay, test yourself. Fine. So there is a baby which was rushed to the emergency room following her mother's complaint that the infant has been irritable, difficult to breastfeed, and has had diarrhea for past days. Okay, so the baby is having diarrhea since a few days, okay, and the child is now irritable. The infant's respiratory rate is elevated, so they're telling that the respiratory rate is increased and the fontanelles are shrunken. So what does that mean? That the child is having diarrhea, okay, and now it is dehydrated. The child is dehydrated. Fine. Now the emergency room physician orders an ABG. Okay, or the ABG results are as follows. So ABG results, let's look at it. pH is 7.39, the PaCO2 is 27, and bicarbonate levels are 19 milliequivalents per liter. Now what does this mean? Okay, let us go with our 5-step analysis. What is the first step? To look at the general condition of the patient. Yes, the patient is having diarrhea and the child is dehydrated. Okay, is it respiratory problem or is it metabolic? Looks like a metabolic issue. Let us see, because of dehydration. Fine. Okay. Second is to look at the PaO2. Have they given the PaO2? No. Fine. It's okay. Next is to look at the pH. What is the pH? 7.39. Is it, where is it? 7.39 means it is between 7.35 to 7.45. So that means it is normal. pH is within normal range. Next, look at the PaCO2. PaCO2 is 27. What is normal? Normal is between 35 to 45. So now our PaO2 has reduced. PaO2 has decreased. Fine. Now look at the bicarbonate. Bicarbonate is 19 milliequivalents per liter. What is normal? Normal is between 22 to 26. So now it is a metabolic issue. Okay, so what happens is, because of this, there let's say there was metabolic, okay, there was metabolic acidosis. Okay, because of that there was a compensatory mechanism, that is respiratory alkalosis. Since our pH is balanced, I would say it is a compensated metabolic acidosis. Okay, why did we say it is metabolic acidosis? Because see, with the dehydration and everything, will we say it is respiratory? No, it is a metabolic issue. Look at the diarrhea and there is dehydration, so it is definitely a metabolic issue. Now with metabolic issue, that is, you need to look at the bicarb levels. Okay, so this will be your primary problem. Primary problem is with bicarb, correct? So bicarb is 19, meaning it is less. Okay, if bicarb means the alkalinity is less, means it is an acidotic problem. So it is a metabolic acidosis. Simple. Because pH is coming to normal, so I am calling it compensated metabolic acidosis. Now if they give you the ions and everything, then you can go ahead and calculate your anion gap. Now but from our mnemonic, okay, if you remember that diarrhea will cause a normal anion gap metabolic acidosis. Okay, normally diarrhea causes normal anion gap metabolic acidosis. So that was a simple question. Now there's a very last question. If people want to, check, test themselves, this is the last question for you guys. Okay, so there is Mr. X who underwent post-abdominal surgery. Okay, he has undergone some kind of abdominal surgery and he has a NG tube, that is a nasogastric tube. Okay, the nurse on duty notes that the nasogastric tube is draining large amounts of coffee ground secretions. Okay, so you have put an NG tube, you're getting like around 900 to 1000 ml, okay, per 2 hourly. So the patient is losing a lot of fluid through the NG tube. Okay, and now the patient is not oriented to time, place, and person, and the nurse soon she gets the ABG, and the ABG shows a pH of 7.57, PaCO2 of 37 mmHg, and bicarb is 30 milli equivalents per liter. Now what is your assessment of the patient? Okay, so again let's start our 5-step procedure. The first step is that the patient is a post-op patient, okay, and the patient is having a lot of stuff coming from the NG tube. So this, I would say, you could equate it to vomiting. Okay, it's as good as vomiting. The patient is throwing up a lot of this one. So you think it's a respiratory problem or a metabolic problem? It is more likely a metabolic problem. Okay, fine. Next, you should look at the PaO2, which is not given here, so that's okay. So next, let's move on to the pH. pH is 7.57. Now it is more than 7.45, so it is an alkalosis. Alkalosis, simple. So metabolic alkalosis. Look at our PaCO2. What has happened to CO2? 37. 37 is, it means it's between normal range, 35 to 45, correct? So this is normal. And look at our bicarb. Our bicarb is 30. That means it is more than 26. So now your bicarb is more, your pH is more, so hence it is alkalosis, metabolic alkalosis, simple. Now look at the I'll write here. So metabolic alkalosis. So now what should be the compensation for this? The compensation should be respiratory acidosis, correct? Respiratory acidosis means what? The CO2 should increase. Now what has happened to our CO2? CO2 is normal, it is not increased, so it is uncompensated. As simple as that. It is uncompensated metabolic alkalosis. Okay, that's it. If someone gives you the PaO2 also in this patient, let me just add that to this question. Let's give you PaO2 and let us say it is 60. Okay, you know that PaO2 less than 75 will qualify to be respiratory failure, and then we have seen two types of respiratory failure, type 1 and type 2. In type 1 the PaCO2 will be normal or low. Because our PaCO2 is normal, this patient will be having type 1 respiratory failure. Okay, so yep, that's it about the acid-base imbalance from my side. I hope you understood the concept and will never get any of these questions wrong. Okay, so if you got any doubts, do mention in the comment section below. And yes, happy new year again, and thank you so much for watching.